Great, thanks so much. So it's my pleasure to open the final little chapter of our panel this afternoon, a discussion of some of our qualitative research findings. So I'll first provide a bit of a background to the qualitative study and set up kind of three interrelated areas of analysis that we're pursuing. And Mark and I, of course, are really grateful to the whole Engage team for supporting this work as we continue to refine the findings I'm presenting today. So in our mental health research, we've learned a great deal about suicide from our participants. The interview material we're reviewing will discuss men's suicidal thoughts, as well as the suicides of friends, family, and lovers. So now for some really brief background, there's a growing popular and academic interest in the topic of mental health and gay men. Since 2007, suicide has passed HIV as a leading cause of premature mortality among some gay and bisexual men. As we've discussed in past summits, there's also been a syndemic link found between poor mental health and increased rates of HIV. In short, mental health outcomes are key to understanding the HIV epidemic and central to improving the health of sexual minority men. And I read a lot of academic literature in my work, but really you just need to come to the summit every year because you see the really leading researchers doing work, including really beautiful and important work by colleagues like Olivier and Travis who presented throughout the summit. So within a growing body of research, gay men consistently rank mental health as one of their top health concerns, but much research tends to remain focused on sexual behavior and HIV. This is the case despite the fact that gay, bisexual, and other men who have sex with men are more likely than their heterosexual counterparts to experience depression and suicidality. Sexual and gender minorities also tend to report higher usage of mental health services, but report lower satisfaction or higher discontent with services, reporting significant barriers, some of which we've talked about at the summit, barriers like stigma, homophobia, transphobia, and biphobia. I think it's really important to note that many people in this room have been doing critical research and critical work in this field for years and for decades. And we're really, as a team, deeply encouraged by the focus of this year's summit on mental health. And Mark and I are both kind of nerdy sociologists, and we like the opportunity to I can call us nerdy sociologists, right? Okay, well, I am a nerdy sociologist, and I feel really grateful to be able to be part of these kinds of discussions. So we wanted to use Engage as an opportunity, as a unique opportunity to answer kind of the following two interrelated questions. How are sexual minority men living in Toronto making sense of their mental health and mental health service needs, and what are their decision-making processes and experiences accessing mental health care in Toronto? So Trevor did a great job of giving you an overall picture of the Engage study as a whole, and I'll just give you a little vignette of the qualitative portion. So we completed 24 in-depth interviews with gay, bi, and queer men living in Toronto. These men were recruited from Engage. They first had to complete the Engage quantitative questionnaire and the biomedical screening. And then we emailed participants who consented to be contacted for additional studies. These participants either had to have had experiences dealing with mental health challenges, severe or less severe, and or have accessed or tried to access mental health services. The interviews were guided by an active interview style. So there was an interview guide developed, and it was refined in consultation with community members, our community partners, and the larger Engage team. And while we outlined a lot of questions, a lot of areas that we were really interested in pursuing, the primary goal of these interviews was really to follow the lead of the participant and get a rich kind of narrative account of their experiences with accessing mental health services and what they wanted to talk to in relation to those experiences and their needs. So those interviews were then described verbatim, and we analyzed them to kind of understand what the key themes are in men's accounts and really understand that across the experiences or the narratives of individual participants, as well as looking at the sample as a whole. So quickly, this is just a kind of snapshot of the diversity in our sample. The age range was between 22 and 59, with a mean age close to 37. 92% identified as gay cis men or used gay and queer interchangeably. We had 2 participants identify as bisexual, one as trans and one as gender non-binary. 40% of the sample was non-white. And 50% of participants had incomes below 40,000. 9 participants were living with HIV, and 7 of the 15 participants who were HIV negative had taken or were taking PrEP. And that's kind of important for some of what Mark will be presenting in a minute. So these are the kind of first 3 areas that we want to quickly touch on today, which are at different stages of development. I'll present this first piece on suicidality, and Mark will present the other 2 analyses, which we're currently pursuing. And we'll be using pseudonyms throughout the talk when we're referring to participants' accounts. So there's been minimal qualitative research with gay men on the topic of mental health and suicidality. This represents a trend indicative of suicide studies in general, which have predominantly made use of quantitative data to provide explanations for suicidal behavior and patterns over qualitative data geared towards improving our understanding of these phenomena. So Summit rock stars, like I mentioned earlier, Olivier Ferlet and Travis Salloway are 2 of the important voices in this field that have helped to develop a growing body of research and attention to these questions. So for example, Salloway and colleagues argue that the leading discourse on gay male suicide has largely been structured around anti-gay bullying and a youth-oriented narrative. Salloway and colleagues stress the importance of bringing in additional narratives of suicide in gay men in order to, quote, enable more ways of making sense of and living with suicidal thoughts and actions in the context of sexual minorities' lives. So I've learned never to turn down an invitation from Travis, so that's what we aim to do. We aim to critically add to this literature by focusing on 5 key interrelated narratives that emerged in our interviews. So in so doing, we hope to underscore an idea of social suffering as an overarching narrative frame I take from the anthropological work of Kleinman and colleagues who were writing in the mid-90s. So Kleinman describes this idea of social suffering resulting from, quote, what political, economic, and institutional power does to people, and how these forms of power themselves influence responses to social problems. The clustering of health issues and social mental distress, including suicide, runs against the professional medical idea that sufferers experience 1 or at most 2 major problems at a time. The grouping of human problems also defeats categorization of such issues as principally psychological or medical, and therefore individual. Instead, it points to the often close linkage of personal problems with societal problems. It reveals, too, the interpersonal grounds of suffering. In other words, that suffering is a social experience. I usually use this summit as an opportunity to reread some theory. Oh, I brought a book. I usually like having a book. It makes me feel like pseudo-professorial. So I'm rereading Arthur Kleinman, who's a medical anthropologist right now, and that's where I've taken this idea of social suffering. I have this dream that we'll create some sort of gay book club. It hasn't taken off yet, but one of these years. So in discussing their own mental health challenges, some of the participants provided accounts of the suicides of family, friends, and lovers. While participants discussed their own histories with suicidal ideation in relation to these events, others articulated that they weren't themselves suicidal. For example, in reflecting on his own mental health challenges after a lover's suicide, John articulated a deep empathy and resonance with the struggles of his former lover, whose life, as he explains, quote, looked a lot like his. His life looked a lot like mine. It's so ingrained, especially as a queer person, as a person of color, and living in this capitalist world where you have to work 40 hours a week to earn your food and shelter. I think that's really harmful, and for sure, there's a lot of reasons why folks who are more marginalized feel that a lot more than other people. In another account of a family member's suicide, Noah detailed the suicide of his father. My father killed himself, and it's just never been on the table for me. At the same time, though, not really since I've been an adult, except maybe for 1 or 2 times. But there haven't. Growing up, there were thoughts like, not existing would be interesting. The example here is important because more than showing the existence of suicide within his network or within his family, there's also a hesitancy to discuss suicidality within his own life, despite acknowledging that he's certainly thought about not wanting to exist. For many participants in our sample, there was a recurrent theme of silence or significant discomfort with talking about suicide. Multiple participants explicitly linked their experiences of self-described internalized homophobia to struggles with their mental health and having suicidal thoughts. While many participants described suicidal ideation or attempts explicitly, others described, quote, approaching that place of suicidal ideation at different points in their lives. Some of our participants expressed repeated periods of suicidal ideation over most of their life course, including as children. For Francisco, quote, internalized shame and internalized homophobia is what he attributed to his earliest suicidal thoughts. I tried to repress that. I internalized a lot. I get a lot of internalized shame, internalized homophobia. Took that out on myself as well. I was overweight, so I had more body issues. So a lot of compounding building up in my adolescence. Some of our participants discussed their suicidal ideation explicitly in relation to their intersectional experiences as gay, bisexual, or queer men of color. For example, Jaden talked about the inability to discuss mental health challenges in his household as a young person and his perceptions that this has now changed. It's like when I was younger, anything that was like, me talking about depression or anxiety was like, it was to my parents, oh, that's gay shit, that's not a thing. HIV emerged as a complex theme in some participants' accounts of suicidal ideation. In some cases, participants who were living with HIV talked about multiple factors and stressors in their lives, but that they weren't able to, quote, pinpoint or isolate a particular social determinant of their suicidal thoughts and actions. Hamid, a queer, gay Middle Eastern man in his 30s who was living with HIV, explained it this way. I just felt like a general kind of waste of space. I went through a period, I was sort of kind of self-destruction, where I kind of, instead of sort of trying to kill myself quickly, I was going to just kind of disappear into a void. So I started seeking out sort of dangerous ways to engage sexually, so then it would become like, sort of like chemsex, sort of the chemsex scene. Maybe if I just kill myself slowly, maybe that's the way to do it. I wouldn't say I wanted HIV. I thought maybe I just would have an overdose first. Rather than conceptualizing HIV as a cause of his suicidal ideation, Hamid's narrative reveals how he understands the virus to be, in part, a consequence of his suicidal ideation and, quote, self-destructive behavior. Finally, Patrick, who was living with HIV, described a recent suicide attempt and how he went off his medications, including HIV medications. While the use of his medications was described as one means of committing suicide, Patrick described a broader set of economic conditions as being central to his desire to end his life. I'm going to give myself this amount of time to find a job, and if I don't find a job at that time, at the end of that time, I'm going to commit suicide. But both times, it was, if I'm not able to provide for myself by such and such a date, then that triggers events afterwards, and that's what I chose to do. Since then, it's more than just earning. It's issues of self-worth, it's issues of coping, it's an issue of anxiety, stress management. There's a whole package of flavors there. But at the time, it was purely earnings, job, black and white. Compounding economic and financial stressors were central to a lot of the narratives of our participants. In Patrick's case, while there were multiple factors, he said, influenced his decisions to attempt suicide twice, including social isolation, it was also clear that financial concerns, rising credit card debt, stressful contract work, he was working in the financial sector, aggravated underlying mental health issues and minority stress factors leading to his suicide attempts. So these are preliminary results that I'm presenting today. However, one of the ideas that's clearly emerging from examining different narratives and the complex ways that they intersect is this notion of social suffering that I presented earlier. In other words, as we in this room know from our work in the field and from the many excellent presentations at the summit, it's not just about one thing or a couple of factors that can be isolated. It's a complex assemblage of issues that collectively lead a person to consider life to be meaningful or not worth living at any given point in time. And this, of course, raises difficult questions about what types of mutually reinforcing interventions would be needed to address such a complex health phenomenon. Finally, we need to ensure that in our thinking about suicide, we don't accidentally or unintentionally repathologize gay men. That is, we don't equate gay men with suicidality, but rather that we're instead mindful of some of the upstream factors that produce increased suicidality among this diverse group. So that's my upstream bear. I also don't want to pathologize bears of any kind, but really that is our looking as using these rich narratives from our participants as an opportunity not just to look at things at an individual level, but really to understand the social conditions of these guys' lives. And it's, of course, also necessary to think about the kinds of mental health services that guys need and the kinds of services that they have barriers to accessing. So with that, I'm going to turn it over to Mark.
Thank you, Daniel. And I want to contribute to the love fest of working on Engage. It's really been, especially working closely with Daniel, engaging with Trevor, engaging with our team nationally, it's really been intellectually and politically stimulating, the stuff that's coming out of it. I have two papers to present. The first one is a paper that I presented at CAR, so maybe some of you have seen it. The second one is a bit fresher, so I'm going to have to read that one a bit. So the first paper is this one, and I'd like to thank my co-authors. And so I obviously don't need to talk about PrEP or U=U or undetectable viral load to this group, but we know that these are emerging, and a lot of the research on this has been about sexual health. So we did these interviews, and we were interested in what the implications of HIV treatment and prevention advances are on sexual minority men's mental health. And here is the main takeaway. There are these two tensions that existed both within individual interviews and across the interviews. One was that PrEP and U=U or TASP were spoken about positively, right? They kind of reduced the stresses associated with HIV, they reduced anxieties, whether people were HIV negative or HIV positive. But on the other hand, even though they reduce the kind of stresses associated with the biological dimensions of HIV, pills don't actually address the social and economic determinants that were causing the HIV epidemic in the first place. It's an obvious thing, but it's an important thing to kind of state. So that was the thing that emerged throughout the interviews was, on the one hand, we're really optimistic about this, but on the other hand, HIV stigma is still a thing, and income security is still a thing, and body image is still a thing, and homophobia is still a thing, and debt is still a thing, even though I'm not worried as much about HIV risk. And I will go through a few examples to highlight that. So the way in which the men we spoke to articulated that tension, there are two different ways. In one group, we had guys stress that HIV was less consequential currently to their mental health, meaning in thinking about psychological and emotional distress, HIV wasn't currently the main factor that was causing them anxiety or depression. And that was, there were two groups within our two subcategories. One were guys that used to be encumbered by HIV related stress, and two were guys that never actually, HIV was never a big concern in their lives. And I'll go through those examples in a moment. And then the second one, the second major category was guys that still saw HIV as major contributors to their mental health, and that has a lot to do with HIV stigma, so we'll get to that in a moment. So to go through some of the examples. So the idea of HIV distress is under control. So these are guys who are saying that HIV is no longer the major factor causing me stress and anxiety, but it used to be. And the people in these categories are people who are on PrEP. And PrEP, HIV negative men who are on PrEP, and as a result of being on PrEP, a lot of their sexual related anxieties have gone away. So we have Marco in his 30s saying, but lately, or let's just say since I started PrEP, I don't know, I just felt a lot more in control and healthy. PrEP just kind of gave me that empowerment to not be scared anymore, not feeling like I had to be reckless. I can do what I want and decide things for myself, end quote. And Cameron at the bottom talked about how PrEP has helped to, quote, deflate an elephant, so to speak. At the same time, what's interesting about Cameron's story is he talked about how he was kind of stuck at his shitty job because he was relying on the insurance in order to pay for PrEP. So it was like this catch-22, like, this is really great, but like, there's this other issue that's not being addressed, which is I hate my job. Another version of the U equals U thing kind of moved. Another version of the HIV used to be a major stressor and is less. This is Christopher, who's in his, I believe 40s, it's covered. And he's a person living with HIV. And he used to be encumbered by HIV-related stresses, but then he said, as a result of U equals U and people on PrEP and the existence of PEP, he's actually felt like HIV is no longer the major thing that he's worried about. So he mentions it here, where he says, quote, well, I don't really talk too much about HIV with my psychotherapist. I'm talking more about why I have bad body image, why I, panic at work sometimes because I think I'm in trouble and going to lose my job. And just like that's happening, it's more other stuff. But like the HIV thing seems not to be what my main issues are for seeing a psychotherapist. It's the other stuff. Again, you have this excitement and this enthusiasm over biomedical advances, but these don't address some of the other fundamental things causing him stress, in particular income insecurity and body image. The next two, another example of somebody talking about how HIV is no longer a major stressor was also a category of PrEP users. So when we asked Lee how has being on PrEP affected his mental health, he said neutral. I'm glad I went on PrEP and I've learned some things and done some new things. I think being on PrEP helped me enjoy bareback sex more, but I wouldn't necessarily say that it was doing anything for my mental health, end quote. And so that's kind of fascinating because sometimes we conflate sexual health with the overall health. But in his narrative account, Lee was like, the things that are actually causing me the most stress is finding a job as a queer man of color in the city of Toronto, and not necessarily my concerns, because PrEP is great, but condoms worked for me before, and it wasn't this major stressor in my life. The things that are stressful, again, are finding work. You're noticing that theme coming up a lot. In the last category, which includes both men living with HIV and HIV-negative men, are guys who still talked about how, despite biomedical advances, HIV was still a key stressor. And this is Samir, who is on PrEP and knows a lot about HIV, but he says, quote, I'm still a child of the 90s. I grew up with that fear of sex as something to be frightened of. I'd be like, yeah, you know what, you're undetectable, I'm on PrEP, we take precautions, and then one day I could just lose my shit. And this is the same kind of version from a man living with HIV, saying, well, I'm taking medication, so I'm undetectable. It's been not the most fun journey psychologically. I think I'm still not dealing with it very well or haven't really learned to accept it all that well, end quote. And Daniel brought up this narrative account before of all the different factors that were going on with Hamid's mental health. But what is very clear in both of these narratives is that biomedical advances don't necessarily erase HIV stigma within a day. And that's something that's been coming up consistently throughout the conference. And I think that's really important, is that you can't just use the rationale of biomedical advances to kind of erase that trauma and that history and that fear that's been built over 3 decades. So very quickly, to wrap up that discussion, HIV remains an important dimension for understanding sexual minority men's mental health, obvious point, but at the same time, the interviews challenge the dominance of a purely HIV lens to understanding mental health. PrEP was sometimes positioned as a quasi-mental health intervention, particularly around anxiety. The other thing is that the positive implications of biomedical advances are experienced and understood differently by different people. I had to be a little bit quick, so I removed one of the quotes, but there was this one man living with HIV who talked about how he believes in U equals U biomedically. He thinks it's great. He thinks he's happy that the message is being sent out, but in his own life, he still feels like a perverted old man. So again, biomedical advances don't erase HIV stigma within a day. And then finally, key social and economic determinants of mental health remain unaddressed, and I am going to hammer that home in the next presentation. So, as Daniel already mentioned, one of our key points of our analysis are trying to understand sexual minority men's experiences accessing mental health services in Toronto. These are very preliminary findings, or we're working through them, so some of the main things that came up from actually focusing on what were these men's experiences accessing services in Toronto. One, we noticed a strong desire to access services to address mental health issues of varied types, whether related to HIV stigma, masculinity, trauma, intimate partner violence, etc. However, mental health supports were characterized as being inaccessible and inadequate. The systemic barriers were so significant that they produced further distress and further marginalization. So people went in to go seek help only to end up feeling more distressed and isolated or marginalized. And the barriers were so significant that many were discouraged from seeking out additional support. And before I describe those barriers, I think this quote, or these two sets of quotes from Lee, really describes what it is that came out from the interviews. And so the first one, I felt like in all my instances of navigating the medical and mental health care system, the bureaucracy and the hoops to jump through and the gatekeeping and the follow-up and the paperwork, it was so draining, so difficult. I felt like it left me a lot to my own devices to have to keep myself from falling closer to that edge. And so this is a thing that I'm trying to communicate, is not just that there are these barriers, but how trying to navigate the system fueled the very problems people were trying to address. And this was something that came up over and over. So I'm going to have to do a little bit of reading, again, because this analysis is fresh. So these are the ways in which currently conceptualizing the barriers. We noted two types of systemic barriers affecting the mental health of sexual minority men. The first were general systems barriers, obstacles to mental health care that were not specific to sexual or gender minorities, but that greatly affected participants' ability to access care. These included issues such as cost, logistical difficulties finding a service provider, including finding a family physician to access a referral, excessive wait times, emphasis on psychiatry and pharmaceutical interventions over other forms of counseling, poor client-provider compatibility, and just unsatisfactory services. The second set of obstacles were sexual and gender minority-related barriers, limitations in the mental health care system that were more explicitly rooted in heterosexism or gender-based discrimination, and thus were particular to the service experiences of sexual and gender minorities. These included dealing with homophobic and or transphobic providers, as well as challenges finding providers with relevant lived experience or capable of providing culturally competent care. And I'll go through some examples in a moment. Though analytically distinct, these two categories of barriers operate synergistically to reduce the mental health of sexual minority men. Both mutually reinforce the negative implications of the other. General systems barriers are more difficult to navigate by someone with a minority status, fearing discrimination, and sexual and gender minority-related barriers are more difficult to avoid in the context of a larger scale system with multiple deficiencies, which greatly limit access to available services. Nonetheless, while these two sets of barriers are highly interrelated, the utility of thinking in and through these categories is that they demonstrate the distinctive ways in which sexual and gender minorities experience additional dimensions of marginalization as well as mental distress when seeking out mental health care. In instances of navigating sexual minority-related barriers, this is through direct harmful experiences of confronting identity-based discrimination and prejudice. And in cases of general systems barriers, individuals unable to afford services or navigate the complexity of an opaque health system were left to have their mental health needs unaddressed and often worsened. In the case of minority-related barriers, marginalization and emotional and psychological distress are reinforced through contempt. In the case of general systems barriers, marginalization and emotional psychological distress are reinforced through neglect. So here are some examples of starting off with some sexual and gender minority related systemic barriers. So this also includes, I didn't include this example, but people who their mental health providers told them that they could cure their homosexuality. And in this particular instance, John was talking about how the psychiatrist, we didn't get a lot of fuzzy stuff about psychiatrists. People were quite critical, but here they were transfixed on my trans history as being like the thing that needed to be diagnosed that was causing me mental anguish, which is not at all the case. So that's on the more extreme version, but Andrew talks about the difficulty of finding culturally competent care. So he met a counselor at school, and he's like, it was okay. She didn't really get a lot of it, the issues related to being a queer man of color. She was like, yeah, like it was okay. She helped me as much as she could, but I feel like the situation was a little bit complex and was some things kind of went over her head. I kind of was hoping that there was maybe someone who was queer or someone who kind of had a little bit more, I mean, she did the best she could. She was really nice, end quote. General systemic barriers, okay. General systemic barriers. So this is Cameron, and he talks about how he tried to access services, and at first there was long wait times, not allowing him to see somebody, and then everything else that was presented to him, he had to pay. And he said, and because at the time a lot of my anxiety was financially related, that became a trigger in and of itself. Like, I want this mental health care, I feel like I need this care, but I can't afford this care. And the fact that I can't afford this care is making me a basket case. So that's the kind of loop that I felt I was in. Then there's Arthur, who's in his 30s. I'm usually moving in and out of contracts. My work schedule is I'm only in a job for like a short period of time. And I never feel comfortable asking my employer for a day off to take care of this mental health stuff, right? Because working is so important to me and making money is so important to me, end quote. And he went on to talk about how difficult it is to afford housing in the city of Toronto. It would be the same case in a city like Vancouver. So these are not things that are specific to being a sexual or gender minority, but these are things that are impacting their mental health in very significant ways. And as a last example of a general systemic barrier, we have this example of Carlos, who had just moved to Toronto as a queer refugee, was dealing with a PTSD diagnosis and a recent HIV diagnosis, and then he went to go see a psychiatrist in a Toronto-based hospital. And basically, to summarize the quote, he was late for his meeting, and the psychiatrist kind of reamed him out and said, since you're late, I'm going to have to charge you for this appointment. Afterwards, he was so destabilized from that, he actually checked himself into the emergency room because of the stress of that, and he was already suicidal. The thing that's really interesting about that, there's so many ways to interpret this quote, but for a second, I actually want to put myself in the shoes of the psychiatrist and not just focus on the fact that they fucked up, but what happens when you're only seeing somebody in 15-minute intervals, when you're backed up, when you're stressed out, when things are moving so quickly. What happens when a hospital system is so underfunded and so stretched out? What happens to those who need the services the most? And so that's what this example is actually pointing out. It wasn't a direct form, at least from the information we got, of discrimination, but it was a system-wide issue that aggravated that minority stress. So kind of to end things off, among our participants, how much time do I have? Okay, whatever time I have. Oh, good. I'll go home with it. Among our participants, discussions of general systems barriers outweighed those of sexual minority barriers, demonstrating the prominent role of more generalized health system limitations and economic considerations in determining the mental health of sexual minority men. Indeed, an important analytical dimension of these men's accounts was the overlap between their negative experiences accessing mental health care and their reflections on the social and economic determinants of their mental health. That is, participants' struggles regarding their need for mental health care were often interdependent with their reflections on the causes of their poor mental health. This was particularly noted in the repeated critiques of the unaffordability of mental health care and the challenges of accessing care in the context of precarious employment, contract work with no health benefits, stressful working conditions, debt, and the rising cost of living. Perhaps most striking about the data was how trying to access the very care meant to address a set of prominent health problems was often associated with reproducing these very health problems, as many of the men described their experiences of accessing mental health care as adding to their emotional and psychological distress. In instances of confronting sexual and gender minority-related barriers, an inability to find culturally competent care or a situation involving a homophobic or transphobic provider were unambiguous examples of how those seeking to address some of the adverse health effects of marginalization were simply confronted with the very prejudice making them ill in the first place. Yet in most cases, mental health care was not considered to be specifically inaccessible to or discriminatory towards sexual minorities, but was just unaffordable and opaque. However, by consistently failing to provide accessible or adequate support to those made more vulnerable to mental health risks, in partial or in large part because of their minority status, the mental health system operated only to reaffirm the social and economic marginalization generating mental health inequalities among this group. Thus, from the data, it is clear that broader structural and macroeconomic trends governing healthcare service delivery and the interconnected nature of healthcare access secure permanent employment, and the rising cost of living are playing a fundamental role in the subjection and adverse mental health outcomes of sexual minority men. Thus, in addition to individual level and biomedical interventions to care, research, advocacy, and community programming will need to critically consider what structural and social economic changes, i.e. in employment, might be necessary to adequately address the mental health epidemic among sexual minorities. And so somebody accused me yesterday, they're in the room, I'm not going to look at them, of always critiquing, but what are the solutions, Mark? And so I'll just pause it. It's very true. I mean, and rude. And sometimes this is where you just put on that nerdy sociologist hat and just, I don't need to give you solutions. I just need to like lay out what social problems exist. But here's the thing that I will say. I'm not necessarily saying these are the solutions, but some things I want to put in our vocabulary. How would the HIV epidemic, or how would the mental health epidemic or crisis among gay men look like in the context of a livable minimum wage, or basic income, or education that was fully funded, or hospitals that were fully staffed? And we don't tend to talk about these things as much, but from the data, they are very significant to the mental health of our communities. So that's it for now.